we're also seeing an increase in marijuana vaping as as well. Nicotine vaping reached a historic high in 2022. Um, Hallucinogen use, for some reason, has also been increasing. I will say that since my training in New Mexico, I am seeing a lot more teens who are using hallucinogens than I did when I was in training or in my child fellowship or residency. So I think that what we're seeing with the young adult population may be reflective or a precursor to what's going to be happening with the adolescent population nowadays and in the near future. All right. So first, we're just going to cover some basics like, so how many kids are suffering from both mental illness as well as substance use disorders? Well, according to a study done in 2012, 1.7 to 3.4% of all adolescents. I have seen estimates as high as 11%. It's hard to get a good idea because states can vary so much in terms of their local use patterns. For example, Arizona teens are 10% less likely to use when compared to the national average. However, in New Mexico, they're 40% more likely to use. So that's one of the things that just makes it kind of difficult to estimate. Um, Estimates on the number of adolescents with substance use who have mental health issues ranges from 50 to over 70%. I would say this is pretty consistent with the adult population as well, with estimates of up to 75% of the SMI population using substances. Right, next slide. So here we have a brief just list of some of the risk factors that are associated with development of substance use and the development of mental illness. I have highlighted in bold the ones that are unique to their respective category, meaning they're not occurring in both. As you guys can tell, the vast majority of these factors are not bolded. So there is a huge overlap. Um, I think some of you out there who are more familiar with substance use and addiction would take issue with me putting community in the mental illness and not in the substance use category. What I will say is that the source that I was using to come up with this graphic and, for my data, um, they had a very different definition of community for the two domains. So for mental illness versus substance use. But this was kind of how they put it. A strong community connection and clear and consistent expectations that someone will not use substances are protective against developing a substance use disorder. Conversely, a weak sense of connection to the community and being in a community where substance use is common can be a risk factor for developing a substance use disorder. So what I would say is that actually community can be considered a risk factor for substance use as well, but due to how they asked the question, it was not listed in that category. All right. So the question we all ask ourselves when we talk to adolescents about substance use, why do it? Um, I will say this quote here highlights what most people in the field believe. Um, However, in most adolescents with a dual diagnosis, a mental disorder typically precedes problematic substance use, and small subsets of young people develop a substance use disorder before experiencing a mental disorder. Um, that is not to say that they cannot develop together, but I think the reason why a lot of people in the field have this view is it's really uncommon to find 5 to 11-year-olds with severe substance use, even moderate substance use. Most of them are not using anything. Um, But you will find a lot of people in the age group of 5 to 11 with ADHD, autism, PTSD, depression, anxiety. Um, so I think that may be why a lot of people in the field have that view of that a lot of times a mental disorder will precede problematic substance use. So substance use as a developmental disorder. This is a new way to think about substance use disorders that I came across. Some of the mechanisms are listed here, such as bidirectional feedback, self-medication, secondary mental disorder. We'll be getting into this more on the next slide, like into the details of what that is. Um, Below that are a lot of the protective factors for that will protect teenagers against substance use. So a positive social orientation, intelligence, strong family and community ties, having some sort of special talent or ability. These are all protective factors. All right. So here, what we're going to do is we're going to kind of go into a little bit more detail about some of the mechanics by which one may view a substance use disorder as a developmental disorder. Um, Firstly, genetics. So Dr. Daniil Dick at Rutgers estimates alcoholism may be 50% heritable, whereas other addictions can be as much as 70%. The University of Utah has similar estimates of, addictive disorders being genetic with ranges from 40 to 60. Um, so just like mental illness, substance use disorders are, have a huge genetic component to them. We see similar things with ADHD, depression, schizophrenia, bipolar, as well as medical, general medical illnesses like high cholesterol, diabetes, heart disease. Um, Bidirectional feedback. So this is another mechanism by which we may view substance use disorders as a developmental disorder, which is specifically how the substance use results in a positive loop, positive feedback loop, which reinforces the behavior. So what is known as classical conditioning. Um, you can see similar issues when you have small children who exhibit a lot of behavioral issues and they get either attention or they get something, some sort of positive reinforcement from it. And thus the behavior continues despite it not, the parent or the caregiver not necessarily wanting that behavior to be there. Self-medication. So mental illness, if it precedes the substance use, can help with their symptoms, such as like, if you have social anxiety, then you may turn to alcohol to help combat the feelings and the anxiety in those social situations. Um, and what I will say is that the role that parental modeling plays in self-medication cannot be understated. So if mom and dad, when they had, a hard time or a hard day at work, and the way that they dealt with it was drinking, it's not unreasonable to expect an adolescent to pick up on that and then use that same coping skill, albeit maladaptive. All right. Before I go on, Katie, are there any questions that, need to be addressed before I move on to substance illness relationships?
So far, no. You're good to keep going.
Okay, cool. All right. So sometimes people will try to self-medicate a mental illness with a substance. And I'm going to list some commonly used substances and illnesses here. So, for example, we already talked about alcohol and social anxiety and how the two, how you can really develop an alcohol use disorder if you are incredibly anxious, and have social anxiety and have difficulty tolerating that situation. Cannabis and insomnia. So there are some, especially with the higher CBD strains, there do have a bit of a sedating effect. And so a lot of times teens will use cannabis to combat insomnia and then help them sleep uh, rather than tell their pediatrician or tell their PCP or tell their therapist that they're having trouble with, falling asleep at night. Um, Cannabis and anxiety. So same thing. A lot of teens will use cannabis to combat an anxiety, especially school-related anxiety. So what they'll do is they'll use cannabis first thing in the morning because they know that they're going to be anxious on their way to school, at school, the whole day. And so they may have to use while even at school to help them combat these anxious feelings that they're having. Um, Methamphetamine and ADHD. So I actually had never even formed that connection between the two until my training in New Mexico when I met a 70 plus year old man who was actually mixing methamphetamine into his coffee. And I had never heard of meth being used that way. And I just asked him, I was like, well, why do you do that? And he just kind of looked at me like I didn't know. And he was like, well, obviously that's how I function. I can't function if I don't do that. And I then asked him, well, huh, do you have a hard time focusing? Oh, yeah. All right. Well, how are you like in school? Oh, I was terrible. I was always getting in trouble. Lo and behold, we did we did a questionnaire for him, and he wound up, having meeting criteria for ADHD. So he was self-medicating his ADHD by mixing meth with his coffee. And the way we approached it with him was we said, why don't we try you on Vyvanse instead? Because that's not illegal and you're not going to get in trouble for it. Whereas the meth, you're going to get in trouble for. And nicotine and schizophrenia. So a lot of people with schizophrenia will use nicotine products such as cigarettes or vapes. And I cannot give you a good explanation as to why. There's just a very high correlation of that. So the opposite can also be true. A lot of times you will have substance use leading to symptoms of a mental illness. For example, um, you oftentimes will see methamphetamine use associated with psychosis. Um, you know, THC use can also be associated with psychosis. Uh, Actually, a there was an article from I think 2014. They compared and they found that actually cannabis was more likely to lead to psychotic symptoms developing than methamphetamine was, which to me was kind of surprising because in my residency, I saw a lot of that methamphetamine psychosis, and to hear that cannabis actually is more likely to cause psychosis than methamphetamine was a little surprising. Binge drinking, THC use and ADHD symptoms. Again, THC has some sort of calming effect. And so there may be self-medication. That being said, if you use a lot of marijuana, your executive functioning is affected. You are less able to, your working memory is not as good. Your focus is not as good. You will, quickly lose track of whatever it is you're doing. um, a lot of these deficits will almost mimic ADHD. And there have been a couple of cases in my clinic where the only way I would have known is because we tested them and their urine was positive for marijuana, because otherwise they were endorsing all these symptoms of ADHD, inattentive ADHD. Binge drinking and depression, there's also a correlation between those two. Um, in some Some believe that it has to do with the sleep and the sleep impairment that goes with binge drinking. I'm not sure myself. All right. So, what do we do when we have an adolescent who is using substances? Well, the first thing you want to do is ask. So, um, at the beginning of the interview, what you can do is you can let them know that you can keep the answers confidential unless someone is in danger or someone really needs help. Um, you know, a lot of teens are concerned about their parents finding out. And I mean, for me, the way I practice, as long as no one's in imminent danger, no one's in danger, um, I will encourage the teen to disclose to parents about the use and, you know, uh, elicit their help in stopping. But a lot of times are very hesitant. So unless I'm worried that this kid's going to wind up hospitalized or they have a friend who's, in a lot of having a lot of issues and might be at risk, then I may just keep it between us, but I would follow them up pretty closely just to see how things are going and make sure that, they're staying safe. Um, a lot of teens are hesitant to just self-disclose, but a good way of figuring out, what is their risk is asking if they've seen peers using substances like nicotine, cannabis, alcohol, things like that. Um, and if they say that, oh yeah, yeah, they're in the bathroom all the time. One actually girl at Aurora told me that the bathrooms at her high school were a hot box. And if you don't know what a hot box is, it's basically where uh, some people are smoking marijuana like in a car, and it's so thick that you can like the smoke is in there and you cannot see what's going on inside. So that gives you an idea of how bad it can be in some schools. Um, if they do say, yes, I have seen kids using in the bathroom or I've seen kids with vapes, then you may want to ask how many of your friends are using these substances. Um, Additionally, you can ask about their home environment. Are their parents using anything? Are siblings using anything? Um, this will tell you this will help you not only figure out their risk, but also what sort of family attitudes may be present about substance use. Um, for example, many parents don't realize that modern cannabis is actually drastically different from the cannabis that was around 20 years ago. Another way you can do is rephrase the question if you picked up on it. I didn't ask, do your friends? I asked, how many of your friends? Similarly, you can ask, well, how much nicotine do you use? How much cannabis do you use? How much do you drink instead of do you? Because it's happened to me actually almost a dozen times where I've asked teens that way. So how much marijuana are you using? And they just look at me like, how did you know? It's like, well, I didn't. I just asked you how much and you just confirmed it. So, um, lastly, what you want to do is you want to check your own beliefs at the door. I know there are a lot of strong opinions about substance use, especially in kids. Um, but you really want to come off as non-judgmental because it's more likely you're going to get an accurate idea of what's going on, how much are they actually using, and what they're actually using. As opposed to taking a very judgmental kind of punitive or, sort of like professorial lecture approach that, you really shouldn't be doing this. They know they shouldn't be doing it. That's not news to them. Um, Lastly, when you need help. So sometimes we all find ourselves in situations when we just feel like this is way too much for me to handle. I really like that the National Institutes, the NIAAA, they came up with this sort of model here for uh, how to kind of triage or how to figure out the appropriate level of care when you have someone with a co-occurring disorder. So as you can see that if you have very low um, a very low burden of mental illness and a very low burden of addiction, probably a lot of those could be managed in primary care. Um, let's say you have a lower burden of let's say you have a moderate burden of mental illness, but a lower burden of addiction. Well, that probably could be handled by a therapist, a counselor, most mental health specialists. Let's say if you have someone who's really using heavily, but there's, you know, the mental health burden is not there as much, you might refer them to an addictionologist or an addiction medicine specialist. If you have someone who has pretty high mental health burden plus a very high substance use burden, you would need to refer them to someone who's both well versed in mental health and addiction. I will say that a lot of at Aurora, we do have a lot of a lot of teens who are homeless, and they often do have a very high mental health burden, a very high substance use burden. So that might be an example of someone who you might want to consider referring to, a higher level of care or someone who can, has more expertise to help that particular patient or client. All right. Okay. Before we get into any specific substances, Katie, are there any questions?
There are a few.
Okay.
One is, can the psychosis secondary to cannabis use improve with time and abstinence?
It can. So basically, what I'm hearing with that is, can it improve on its own by just stopping the cannabis use? And I would say yes, it can. Um, I will also say that a lot of times teens will ignore it. Like they will ignore the early signs of it. This would include like shadowy figures, paranoia, ideas of reference, and kind of the milder psychotic symptoms. And they'll just kind of brush it off as like, oh, I'm just being silly, or I'm just, it's just my brain playing tricks on me. And oftentimes, though, when it gets to the point where, like, for example, I've had teens at Aurora who refuse to come out of their room and think that their parents are actually trying to poison them. That's, at that point, you really do need antipsychotics, because the level of dysfunction is so bad that, they can't live their day-to-day life.
Is that something, would the medication have to continue, or over time would that be able to be decreased?
I wouldn't say it's a forever thing. Typically, what I do is I will treat them acutely for a 3-month period and then kind of see what they would like to do. Um, we can attempt a taper after about 3 months and see how things are going. But if the psychosis recurs, then I'm going to go back to the old dose and keep them on it for a year with no symptoms. After that year of, them being, free of any psychotic symptoms, then I may try another taper and try to get them off of it completely. Now, if that taper fails, they may need to be on it long term.
Okay. Okay. And then how long after THC withdrawal will a patient regain their regular mental functions, i.e., regular sleep patterns, less ADHD-like symptoms?
It's hard to gauge because some people will self-discontinue. Some teens I've seen self-discontinue and they will regain it within a month. Just keep in mind, if you're a heavy chronic user of marijuana, THC will most likely be in your system for about a month. And although the quantity is less, the THC will still be present for, you know, 3, 4 weeks. So it could take a month, it could take 2 months, 3 months. Um, there is something known as post-acute withdrawal symptoms, and that I've heard of cases going on for like months or years. Um, you know, and how does that differentiate, let's say, from a primary ADHD? I asked that same question to about cannabis-induced psychosis actually to my teachers in New Mexico. I asked them like, so let's say, for example, this guy stops using marijuana and his psychosis, you know, doesn't go away, and he's stopped for a month. THC has been out of his system for a month, meaning he's had negative UDSs for 4 weeks, and he's still psychotic. At that point, when does it become a primary psychotic disorder? And the answer they gave me was a month. Was, if they haven't been exposed to the substance for a month, but they're still having those symptoms of a substance-induced illness, at that point it shifts over to a primary disorder, such as like attention deficit or psychosis.
Okay, thank you. And can you give examples of what antipsychotic you are using for marijuana?
I often like Seroquel or quetiapine. Um, there's nothing special about it. I will often use other ones like risperidone. I may also use lurasidone, Latuda, or Perpozole or Abilify. But if there is cannabis use and a fair amount of it, I often opt for quetiapine or Seroquel because there was a study of about, I want to say it was like 40 or 50 adults who had really heavy cannabis use. We're talking like at least daily. Most of them were using multiple times a day. They were put on quetiapine, 300 milligrams in the evening, and a lot of them reduced their use from chronic, heavy, everyday use to light or moderate use. Um, I think the studies, they were hoping to get remission, like just stop using altogether. But if I have a choice, I'm probably going to try to use Seroquel, over other ones because there is at least data on that. The other thing is if you ask teens, well, what does the marijuana help you with? Sleep, appetite. Seroquel can also help with both. So I often use that one.
Okay. And then the last one for this round is Kratom, what is safe detox protocol?
Oh, yeah, cool. So yeah, we'll be getting into that. I'll go over that, don't worry.
Okay, perfect. Then take it away. All
All
yours.
right. So, in terms of like these substances, nicotine, marijuana, alcohol, we will be getting into kind of more detail on those in the next slides coming up. Um, Fentanyl, opioids, you really need medication-assisted treatment. The relapse rate is pretty high. Um, Fentanyl is just highly addictive, and the withdrawal is pretty bad. So unless they're on a medication-assisted treatment, the outcomes are not that great. And that's just according to kind of the research, the data that we have available. Um, I would emphasize, though, that you don't have to be on it forever necessarily. Uh, we in addiction psychiatry, we use two measures. One is when people go into early remission, which is after 3 months, and then sustained remission, which is after 1 year. And so what I tell patients when they ask me, well, how long do I need to be on this? I'd say about a year. You need to be on it for a year, get a good amount of sobriety under your belt, really, work on some of the stuff that you might have been self-medicating with fentanyl or opioids, and then we can get you tapered off of it. Um, Methamphetamine may be a good idea to test for fentanyl as well. There are not a whole lot of good treatments for meth use disorder. Um, Basically, it's just contingency management, which I'm not actually aware of any programs in the Valley that are doing contingency management. But that's probably the only one that I've seen that works really well. They've tried stimulants like Vyvanse, Adderall, modafinil. They've tried Wellbutrin and naltrexone. Wellbutrin and naltrexone did have some decent results with it, but it's by no means, it's nowhere near the kind of efficacy we have with buprenorphine and opioids. There was some decreased morbidity and mortality in a European study when they basically put people on Vyvanse or modafinil, and they had stimulant use disorder. Um, Hallucinogens and psychedelics. It's very difficult to treat. I actually asked one expert on hallucinogens in my training, like, well, if you have someone who's just using them, recreationally, how do we treat that? What would you recommend? And he said, honestly, enroll them in a trial, which I found interesting because there are trials out there which are trying to figure out if we can use psilocybin for major depressive disorder, alcohol use disorder. And so that's what his response was just enroll them in a trial. And then when I told him that, well, I work with a lot of teenagers, he said, oh, well, I guess you're out of luck then. So, benzos, occasional use, less problematic than regular use. The detox is more prolonged than it is with alcohol. There's a high risk of complications. And let's see, kratom. So kratom is essentially it's a stimulating opioid. It's, to my knowledge, the DEA has not listed it as a schedule, any of the scheduled substances. Um, and a lot of it's like I've had a lot of times that I have had to detox off of it, and they usually bought it online through some website, and it usually comes in capsules or powder. The way that you detox is basically the same thing for opioids. You can use the non-buprenorphine opioid withdrawal protocol, which it uses like clonidine, lofexidine, as well as a bunch of other as-needed medications, or you can use your standard like buprenorphine methadone protocol. Ketamine, I've only done one case of ketamine addiction, and I just had to them off of it slowly. Um, it is, I know, in England, where there have a lot of, I think somewhere 5 to 10% of young adults were using ketamine recreationally pretty regularly. It can be pretty dangerous, especially because you can get this very odd cystitis, which is a bladder inflammation from it. And you pee every like 5 minutes or something. It's pretty bad. All right, so substance-specific concerns. Here's why is marijuana is just so different from marijuana years ago, 40 years ago, 50 years ago. Back in the 70s, the average THC content of a bud was less than 2%. But if you look at it in 2020, the average content has increased to about 7. Now I've seen flower with content regularly in the knees, and I've seen as high as 35. So back in 2020, it was this high, but it's gone even higher now. That's why I think what we're seeing is an increased rate of psychosis associated with cannabis use. I will admit that when I was in high school, I knew people who used marijuana pretty regularly, and I graduated here. I don't remember hearing about cannabis-induced psychosis like at all when I was in high school. I think that once in college. But now it's like I'm getting teenagers routinely admitted with cannabis-induced psychosis. I think that is in no small part the increased potency of what's out there. On that note, I will talk about what are the different forms of cannabis concentrates. So all of these are essentially cannabis or THC, just different forms. So batter or butter, as well as shatter. These are pretty potent. They're basically THC from a cannabis plant that's kind of been solidified. The highest you'll get with it is 90% THC. There are lower potency products that exist. Cannabis oil. It's the basis for metals, as well as vape parts, and that can be 0%. Crystalline is isolated cannabinoids, and usually you get this in the 99% THC. Like this is your kind of pharmaceutical grade cannabis. Dry sift, also known as keef. This is ground cannabis that's been filtered, behind the trichromes, and this is sort of the end product. Rosin is sort of like in between keef or dry sift and these three. It's kind of just in between these three. I'm not sure. This is the production method. Like basically, just have a flask squeezed under high heat, high pressure, what you see out of it. But yeah, like I said, in terms of potency, it's somewhere between keef, dry sift, and these. Keef, dry sift, that potency can range from 75% THC. Lastly, we have bubble hash, which is when you use water, ice, mesh screens to pull out the trichomes, and then you put into a paste consistency. This is more potent than regular flour, but it can be, as potent as low potency keef. So I was anywhere from like maybe 30% to 50%-ish in that range. All right. So when we talk about nicotine, I always get asked this question, well, how much nicotine is in a nicotine vape? The answer is, well, it depends. So one example would be Geek Bars. They come in nicotine-free, 10 milligram strength, and 20 milligram. However, this can be expressed as milligram per milliliter or percent. So for example, you may have a website or shop that's listing the nicotine content as 5%, and the vape cart has a 16 milliliter capacity. I mean, somewhere there's like about 800 milligrams in that vape. That's equivalent to about 20 to 40 packs of cigarettes, roughly. Retailers are selling zero nic products, and it's very hard to distinguish between the two. As an example, I'll show you guys what something I pulled from a website. So these two, one has no nic, one has nicotine, 2 milligrams, which is pretty hefty dose. There's no way to visually distinguish between the two, other than this little thing here that says 0% nic and 5% nic. Otherwise, I mean, you can see that there's not much difference between them at a glance. So that's kind of one of the challenges that we have is we really don't, kids often don't even know what they're using. All right, so other concerns, propylene glycol, propylene glycerin, these are often used in food as well as cosmetics. However, when you have a vape, it vaporizes these compounds and when we haven't really studied them vaporized as much. We don't know what happens if I vaporize glycerin or propylene glycol. I know if I eat it, it's safe, but if I vaporize it and inhale it, not 100% sure. And I don't know if it's going to cause irritation in the lungs or the nasal mucosa or anything like that. VOCs, all volatile organic compounds. As an example, formaldehyde is a VOC, and these often will get produced if the wrong amount of e-liquid is dispensed. Flavorings, so there are certain flavors that have diacetyl in it, and that's been linked to popcorn lung. Popcorn lung is when your tiny airways in the lungs get closed off by inflammation, and so it becomes very hard to breathe. Nicotine itself, can lead to cardiovascular changes, such as air constriction, increased blood pressure, increased heart rate, and it can impair the ability of cells in the lungs to fight off infections, increasing the risk of this infection. All right, then there's vitamin acetate or EVALI. So EVALI is basically an e-cigarette or vaping product associated lung injury. The symptoms include shortness of breath, coughing, pain, nausea, vomiting, diarrhea, fever, fatigue. It has been linked to vitamin E acetate. So just like with the cell phones and other devices that are powered by lithium batteries, there is a risk of explosion that can happen if you are charging them incorrectly, storing them incorrectly. And a lot of times the teens don't realize that. They know that their phone battery that may explode. They may not realize that the vape does too. Other concerns include possible modding or hacking. So in addition to the issues with the actual nicotine or the juice, people can modify or hack vape devices, and that basically is a post-market modification, which is of the vape device. It can be a change in programming or the actual change, a physical change in the device itself. So what some common modifications can do is increase the amount of liquid, and that can be problematic because of what I mentioned earlier about if you have the wrong amount of e-liquid, then you wind up creating formaldehyde. Other modifications include increasing the temperature, which sometimes they do to get more nicotine. One of the most common mods is to take a non-refillable into a refillable one. So legal geek RCs are non-weights, meaning they're disposable. You don't refill them. You use them, and then but to save money, some people are trying to convert these into refillable. And the problem is that you're changing the way that the manufacturer intended for the product to be used. Like if they sealed it from the external environment and you're opening it, exposing it to the environment, creating ways for moisture and other things to leak into it, that's going to result in a product that's not going to either work as well or could potentially be dangerous. I guess for an example, you can say if you have a plastic fork and just use it for years on end to eat food, probably, it's a one-time use. It's an implement intended to be used just one time, and using it repeatedly may have unintended consequences. Another is you can bypass the safeguards that are built into the device. For example, the device is light that will tell you when your hit has now basically you've taken the maximum amount of nicotine in and you need to stop. And so what sometimes you can do is make it so that light come on. People learn from friends and social about how to kind of mod or hack vape devices. I think most learn from their friends, although social media is a major source of information for how to do these things. All right. So in terms of alcohol, this is another substance that is commonly used among adolescents. Some of the patterns that are different between teens and adults is that binge drinking is the norm. This is for a variety of reasons, but I've included sort of the most common ones here. Adolescents have a higher trust level than adults do. It's illegal for them to drink, and so when they have an opportunity, they will use it as much as they can because those don't come by frequently. An adult who's over the age of 21 doesn't have to hide it as long as they're drinking in moderation. Also, it can be very expensive to. So Oftentimes, if you have a certain amount of money, like let's say if you're a teen with a part-time job and you get your paycheck, you're tempted because of all these other factors, you're tempted to use the alcohol more quickly, and therefore you're going to buy a lot of it. Um, Teens also use typically less of your like reasons that it's residency, you can get more bang, so to speak. Teens also have less coping skills typically than adults do. So it's another way that they're likely to use alcohol to cope, as opposed to adults, although plenty of adults will do the same thing. Risk-taking behaviors, teens in a baseline are just more likely to take risks, especially that increases drastically when they're intoxicated. All right. And heavily influenced by the environment, teens are heavily influenced by the environment that they're in, specifically with peers and parents. So they are much more likely to use if their siblings, parents, or friends are using. Lastly, the other thing that really gets alcohol usage in teens is they're often sharing drinks. It's not just one person drinking one beer or one, it's them sharing a whole bottle of something. All right. Any questions so far?
Yes, there are a few. Okay, thoughts, research on teens using marijuana to self-medicate for symptoms related to depersonalization/realization.
I mean, I don't know of any trials where they've used cannabis even in adults to address that. So I would say generally it's just not a good idea for teen cannabis, because most of the time they're buying very high potency products, like carts especially, which are 90% THC, because they're trying to hide their use from others. So it's way too much THC. The way that the cannabis plant was, I'll actually just go back. So the way that the cannabis plant was evolved, it basically has in nature equal components THC and CBD, and the two kind of balance each other out. What's going on now is we have these things running around which are pretty much pure THC, and the problem with that is you have no CBD balancing it out. So if I were, for example, to take a hit of shatter or distillate, and it's like 90% THC versus a flower, even if it's 5, that's like almost taking 45 hits off of the flower, like a joint with 5% THC in one hit. And so that's one of the reasons why I would advise against using cannabis products, because teens often don't know what they're getting. Now, in theory, if you had a teen who, let's say, their parent grew marijuana, and their marijuana is 5% THC, 5% CBD, and is I would be less opposed to that, but I still think it's probably better to maybe explore that in therapy, or as to why these disassociations are happening. Where are they coming from? Did you go through a trauma in your life, or is there something else going on? And if that's all done, and no one can figure out why, and all the other treatments have failed, then yeah, maybe when you're 21, you can try very low potency THC and CBD and see, and maybe that can be the way that you sort of cope with it. But that would not be my first suggestion.
Okay. The next one is this point available to participants? And yes, it will be that, and the CEU will be sent out to email you to register within the week. This one's for you, Dr. Ghafoor. What do you say to a parent that feels their adolescent is lacking serotonin and it could help with their mental health with a substance as a supplement or by itself?
Are you talking about marijuana?
That's what it looks like. That's what I believe.
Okay. Well, if it's marijuana, what I would say is that if your parent are buying your child a product from a dispensary, firstly, technically that's illegal. You're not supposed to do that. Secondly, there are better, safer ways to increase the amount of serotonin in your brain than by having to rely on marijuana. When I prescribe a patient, it has a controlled chain of custody from the manufacturer all the way down to the pharmacy. So we know who's kind of had that medicine, and where it's been. When I go to a dispensary, usually I'm lucky if they have an analysis on the bud product. Like, let's say if we're talking this flower, I'm lucky if they can produce a chemical analysis saying that here's where we sourced the bud, here's how we know no pesticides were used, here's how we know that this was not exposed to any modifications after it was harvested, all that stuff. Maybe the dispensary has it, maybe it doesn't. But also, you're at that point for a flower, you're paying about, I don't know, $30, $40 for maybe several nugs, like pieces of marijuana, and a prescription for sertraline is $5-10 a month. So makes me also play a role.
Okay. I had seen often drink mugs with an orange and tinfoil thrown onto the roads. What drug is being used in this case, if known?
Orange mugs with tinfoil on the side?
Yep.
Huh.
with
So
tinfoil and they're thrown on the side of the roads.
it sounds like a rig. So a rig is what we call an implement to use a certain substance. I'm not sure why a particular rig that's for. I'd have to Google that honestly, and or I'll have to just search the internet for these answers because it's not like I can go to the APA and ask them.
Okay, and backing up on the serotonin one, she was referring to serotonin in place of methos for ADHD.
Well, I would say if it's ADHD, that's actually not a serotonin. I don't think that's not serotonin. That's more dopamine. And if you're talking, well, what do I tell a parent who doesn't want to start their kid on ADHD medication because it's not natural? I have had a lot of parents like that. I would try to figure out what is the main concern. A lot of parents have told me I don't want my kid being a zombie. I don't want my kid becoming a robot. And the best way to address that concern is by the prescriber. The prescriber has to be family receptive to their fact. If the dose is too high, if they're saying this is not what we signed up for, my kid's a robot or a zombie, the prescriber has to be sensitive enough to and that and then taper back on the dose. If they feel like that they just don't want something artificial to change their kid's brain chemistry, um, I mean, the pick is look, your kid's brain chemistry is already being changed by just the environment that we're in. Humans evolved to survive in nature. We did not evolve to sit in a chair in front of a computer for 8 hours a day. That's not what this body was intended to do. And yet that is what most humans are doing. And so you expect a child who maybe if this were 1,000 years, be living in a village, farming, exercising all day, they probably wouldn't need ADHD medication if that was, but that's not where they are. They're in a classroom with an overworked teacher in an understaffed school who wants them to sit in a circle, in a neat circle, and be quiet. So,
Okay. This is two different questions, but related. Are there any health concerns with using no nicotine vapes? And the second is, can you refill with other drugs than nicotine?
you can refill with anything that you can dissolve into this. Let me see. All these are concerns extremely. So remove this one. All these are still concerns um, with a non-nicotine vape. And yeah, I mean, like I said, you could fill it with whatever. If yeah, I mean, you just have to be able to dissolve it in propylene glycol or glycerin. Do it.
Okay. The next one I think I'm going to say this, I have some questions on it. We can talk about it further in the end. But getting a lot of excellent presentation and information. People are really appreciating this presentation, Dr. Ghafoor. So if you want to carry it forward, we'll go a little bit longer since we've been answering questions. We have 10 minutes remaining for questions at the end.
All right. All right. So next, I'm just going to give you guys like little sort of panel of what the kids are using nowadays. And I have done it in the size correlates with how frequently I've heard of it. Like heard of them using it. So Pink Whitney is the one that I hear the most, especially like girls. They Pink Whitney for one's drinking it. So 30% alcohol by volume. It is a vodka. Buzzballs, especially the Buzzball Biggies. Those are another popular one. It's 50% alcohol by volume. Twisted teas are very common, 4 to 5%. I would anticipate that I'm Buzzballs and Pick Whitneys are, I think, more associated with like binge partying. Twisted teas, I could see teens sneaking that from someone else, sibling, a parent. Fireball, and I've heard a lot talk about using Malibu. Those are 33 and 21% respectively. Jose Cuervo, which is 40%, and Hennessy, which is 40 to 46%, are less common, but I have heard of them being used. Some adult options that I've almost never heard teens say that they drink: wine, especially bottled wine, IPAs, Everclear, and they barely ever. And I haven't heard a single one say those. Maybe a High Man, but that's about it. All right. So more stuff about alcohol. So when we talk about blood alcohol content, we express it as a percentage. So if you have 0.05, what that means is you have 0.05 grams of alcohol per deciliter of blood. And as you can see, as the arrow shows, the higher you go, the more impaired you are. So when we have mild impairment in this, I'll say like typically below the limit, you got mild speech impairments, mild memory problems, problems with attention coordination. You may feel more relaxed and you may feel sleepy. Now, when you're getting beyond the legal limit and we're talking about like, pretty moderate, a pretty moderate blood level, now you're getting like more relaxed. You may get an increased risk of aggression. Now you're getting your problems with speech, memory, attention significantly. This is where you really get impairment in trials, and that's why they put that limit at 0.08. There's an increased risk of injury to self and others. Your memory impairments are no longer, they are moderate, meaning you may have gaps in your memory. Then here to the severe range. I have seen teens present with this much in their blood to emergency rooms. This is not out of the realm of possibility for an adolescent. speech memory coordination, all of those are really impaired. You really should not be driving. You basically cannot drive. Your judgment, your decision making, really, you're probably going to black out at some point when your BAC is up here. You're vomiting and you're losing consciousness. Life threatening. Thankfully, I haven't had a teen in this range yet. I hope I never do, but I have seen imaging in this range. This is where you have loss of consciousness, alcohol poisoning, significant risk of death, because at this point your vital organs are shutting down. In terms of withdrawals, here's kind of where you have the risk for seizures, as you'll see, like the highest risk in the first 2 days, and then it slowly tapers off. Usually by day 7, you're okay. The severe withdrawal can persist up until day 7 or even past that, where you have vomiting, agitation, tremors, just you start seeing things that other people are not seeing. Mortality can be up to 40%, especially from infections, fever, fluid loss. Less than 1% with adequate treatment. And then mild withdrawals here. You have your anxiety, agitation, tremor, nausea. Your sleep is disturbed. You feel feverish. Most of the time, you have teens in this area. It will go through mild withdrawal. Sometimes you will have teens who are in severe withdrawal, but most of them will be in mild, and they'll kind of go through it. That's that. Right. Potential issues when dealing with people who use substances, cross-reactivity. Your screens are not perfect. Reactivity and cross-react does happen. Me false positive. I think that if it's better to send it to a lab rather than arguing with the patient for 20 minutes. That will resolve it. Problem you run into is the patient not want to pay for the lab fee to run the analysis on it. Contact highs. I hear this one a lot. Contact highs typically do not cause positive screens unless you're doing a hair screen where you're taking hair and analyzing it. Contact highs, it's just not high enough concentration substance to really, result in a positive screen, typically. Staff training, you have to make sure your staff know how to perform a UDS and can read it. I'll give you an example of a clinic. There was one clinic where I was at, and they were saying that, the provider there was happy because the patient tested positive for meth, and because they thought that the patient is on methylphenidate, so it means that it's in their system. And I told them, like, no, that's not methylphenidate, that's methamphetamine. That's what they're probably. Yeah, so to make sure your staff and your providers know how to properly read the results. Parental outcomes are much better when parents can abstain. There have been numerous studies on cigarette nicotine use that demonstrated this pretty reliably and pretty well. Why is it the case? Explanations on access. It's harder for a person something when there's no access to it. To parental modeling. These are both valid explanations. There are probably others out there, but I thought these were probably the most reasonable. Other stuff would be medical mess. Usually not an issue in teens, but if there are any medical complications that place the patient at increased relapse or medical sequelae from use, such as IV drugs, or again with vaping, respiratory issues. Let's see. If a teen in treatment becomes pregnant, the good news is that this helps maintain sobriety. I've seen a lot, we had a pregnant substance use clinic for pregnant women at UNM where I trained in my addiction training. I've seen women do remarkable things in terms of recovery, in terms of sobriety with it and substance use. Like I've seen women just stop cold turkey things that, are very, very difficult to stop. And they just did it. So there's a very strong drive to protect the baby. So usually when you have a pregnant person who's using, they will, there's a lot of incentive to stop using if they have the right resources available to them. However, there's also risk because what happens if they miscarry? What happens if they're in a very bad relationship and they're being abused physically? All of this is what happens if you have a partner who is exploiting the woman. All of these can cause issues and can increase the risk of relapse. Legal. Teens can obviously get in trouble for status offenses, such as, drinking and using marijuana and nicotine vapes. Drug can have good outcomes for teens. A very strong reason for teens to not use when they're enrolled in the drug program. The problem is once they graduate or leave, the risk of relapse is really high because all that pressure, that incentive is no longer there. That's it.
All right, because a few questions look like they'll have a little bit to the answer. So Rose, as to how many studies there are environmental factors, pollution, food additives, heavy metals or PFAs, etc., that has or may have contributed to adolescent mental health. And she asked that, she said, because the more we introduce chemical additives, the more we may see mental health disorder in adolescents and possibly more substance use as a self-medication.
I'd have to delve into it and look at that. But yeah, I think that environmental contaminants are definitely something that is a concern and we probably should be looking into. I do know that, for example, I think there are some there that have shown that like secondhand tobacco smoke exposure increases the risk of a child developing anxiety. I know that in utero exposure to cannabis, methamphetamine, and all increased likelihood of developing ADHD. In terms of like plastics and just air contaminants? I do not know. Yeah, but yeah, exactly. So yeah, in short, I don't. But good
Okay.
question.
Yes, very good question. Um, Gilbert asked, when this presentation is shared with us, will I be able to share with my fellow school nurses? I would like to hear more of Dr. Ghafoor's in-services. So is he okay to share those with his fellow nurses?
Yeah, you can share the slides.
Okay, excellent. Um, so this part, what is the best course of action if you suspect your child is beginning to experiment with marijuana or CBD? I had a question because I know some of our directors of outpatient services struggle sometimes working with the adolescents using marijuana and the parents buying into the treatment. Sometimes the parents are using and they don't really see an issue with their adolescents using. So that's kind of, I added on to Willie's question there.
Okay. So, sorry, what's the
First
question?
part is do you do if you suspect a child is beginning to experiment with marijuana or CBD?
Hmm.
And then my part's the parent piece of that. How to help
Okay.
the parents buy in.
So I think the first thing when they're starting to experiment, what I typically do is I try to get a real good sense of what's their world like. You know, where did they come across this as a potential like activity? Was it a parent, a peer? Um, that will, you know, tell you a lot about what's going on in their life. Um, the next thing I would ask is, how does it help? Which is a very odd question to ask, but it is an important one because usually, teens are not dumb and insane. They're going to do things because there's not. And so my guess is usually that the usage is doing something for them. There is some reinforcer there. It may be as simple as, I mean, this that I'm bored. And at that point, you really have to kind of MI and eliciting change talk from them, like, okay, so you're bored. Well, how else do you use your time? What else do you enjoy doing? Do you have any goals or ambitions? Most teenagers want a car. That's enough. Oftentimes, I'll try that route. I'll say, I assume you're having to spend money on this stuff. Are you, and if they're old enough to have a job, I may ask them, like, well, do you have your driver's permit? Do you have a job? Um, and usually they'll say, oh yeah, I want one, or I want to apply one. And I'm like, well, do you feel like to help you get a job or not really? And then really put it, utilize a lot of MI type skills to kind of elicit a lot of change talk and reinforce their reasons to not use. That's typically do. In terms of the parents buying in, no, very, very, I've seen very few parents who genuinely harm their kids or who really don't care about their kids. Most parents have good intentions, and when they buy into something, I guess, what I do is I ask them, like, so what is it you're hoping to address with the, like, marijuana? What is it you're hoping to get out of your child using it? And a lot of times they'll say, well, it's natural, it's an alternative to the pharmaceutical industry that's poisoning our country and has all these, special, and is lobbying Congress. And I don't disagree with any of that. I tell them that. Look, I tell them I don't know if there's any pharmaceutical reps here, but I have no love for the pharmaceutical companies either. That being said, their primary goal is to make. That is what companies do. This whole country is based on capital making money. So expecting them to act benevolently, is not reasonable expectation. They're in it to really make money, and so are the dispensaries. I don't think there's too many dispensaries. I mean, I don't know that many dispensaries out there that are like mom and pop shops that are, selling like really good products that are low potency. And, the dispensaries I see often are like Mint Dispensary, TrueMed, these large dispensaries that have multiple locations making tons of money. I really don't see much difference between them and the pharmaceutical companies. In fact, I think in some ways, like I think the pharmaceutical companies are a little better than them because the federal government monitors the pharmaceutical companies. There's limits on what they can do, right? As feds are concerned, all the dispensaries we have in Arizona are illegal, which means we have no role in regulating them. We're going to regulate something that we believe is illegal. So it's like telling, the state troopers or the police who's selling meth. They're not going to do that. So that's my spiel to parents is that, what are you trying to get out of it? And then providing some education about like what is really the difference between psychotropic medication and product that comes from a dispensary. So, in regards to ADHD, what I tell them is, well, I have data if we treat the child's ADHD. I have data that will show if you treat ADHD prior to the age of 12, their outcomes are more in line with neurotypical kids than neurodivergent kids, meaning that they tend to go down that college route or trade school route. They tend to go down the other routes. If you treat after the age of 12, their outcomes are more in line with kids, who did not, basically, don't wind up going to higher education.
Okay.
So, yeah.
Okay, we have a couple more questions, but in case someone has to jump off, I know people are going to be interested in finding, this is a website for Transition Center in Tempe.
Yeah, so it's www.transitioncenter.com, and that's transitions with an S.
Excellent. And we'll get that information out. We are still asked the question of the PowerPoint. Yes, I will send PowerPoint and CEU certificates to the emails you all use to register for this. In addition, I'm going to send a flyer for Dr. Ghafoor's next CE webinar with us on June 25th from 12 to 1:30. And that one is going to be interventions for different state change. And if we have a few minutes, I'll have Dr. Ghafoor tell us a little bit about that webinar. But the next two questions, what kinds of trends are you seeing with juveniles and hallucinogenics?
Use is picking up. I'm seeing a lot more teens using things like mushrooms, acid, some LSD. Also, I'm seeing them use more pharmaceutical products like coughs, dextromethorphan, Benadryl, things like that. That's what I'm seeing, more in terms of the hallucinogens. I find, honestly, if I'm being very transparent, I find that population of hallucinogens is kind of frustrating for me to work with because there's some really, bad stuff that can happen with hallucinogen use. And it's like, like for example, HPPD, which is essentially if you're tripping, you will see geometric shapes, the walls will melt, all these things will happen. You'll be in a very distorted sense of reality. And what HPPD is that happens randomly out of nowhere 10 years after you stop using. So you could be driving down a freeway, you could be taking care of a child, and all of a sudden the wall starts melting and there's like, these little, figures in the air and you don't know what's going on. When I talk to teens about that, it's sort of like talk to, college students about retirement. They're like, oh, yeah, no, that's not going to happen to me. But like I've treated patients who've suffered from that and we really don't have any good treatments for it. I mean, some are advocating for the use of clonidine to help with that. Antipsychotics don't seem to think, if not make it worse. I don't tell them is if you develop that, I have nothing for you. If you come to my clinic that, hey, doc, this is what's going on, I need it to stop because I can't drive. I'm a truck driver and I on the highway and crash into someone because of this stuff. I'm like, I'll give you like maybe quantity might help. I don't know. Like, there's really nothing out there.
Okay. And then how hard is it to come off Suboxone?
Mm, well, depends. Physically, not that hard. Mentally, can be difficult. If you're talking about physical dependence, you can taper them very gently. Or, I mean, physically, you can get them off in like a month or two. Psychologically, that's a whole different battle. A lot of times people have developed an attachment to the, Suboxone to the view because it symbolizes to them their sobriety, how they got sober, and to let go of that piece of their sobriety, it's very challenging at times.
Okay. So just great information. Thank you so much. Looking forward to part two. Informative. Thank you. Thank you, Dr. Ghafoor. Another question. Are you seeing an increase in huffing of aerosols?
Usually the aerosol huffing happens in middle school. Maybe in a little bit. You usually, by the time you get to high school, there's better stuff available. So I think that don't I don't think so. But again, just at Aurora, we just started seeing more 12-year-olds, which is the school population, because we were originally, I think, our cutoff was 13, and we recently just expanded it to 12. So now that we're getting middle schoolers, I think probably seeing a bit of an uptick, but I cannot say for sure. I'll be honest, to me, most of the time they're using things like, fentanyl, marijuana, alcohol. They moved on to that kind of stuff.
Like I said, a lot of highly enlightening and informative. Thank you. So I think a lot of people, we have 3 minutes left, are excited about part two on June 25th. So if you want to just share a synopsis of what you'll be talking about on that day.
Sure. So
Great.
one of the biggest myths out there is that you can't do anything for a patient or a client who's pre-contemplative, or they have to hit rock bottom before they're ready to change. And that I know that in a lot of the 12-step based programs, that's kind of, a lot of people have that belief. I act 12-step. I think it works really well for a lot of people out there. My only thing is it's very hard for teenagers to hit rock bottom. They have a huge safety net there. Their parents, their school, everyone's gonna, try to help them out. And so for a teen to hit bottom, I mean, by the time they do, they're usually in their early to late, probably even 30s. They've burned all their bridges. So by that time, that's when they hit rock bottom. So what the next topic is going to be about is what we do for people who are at different states of change. So if they're pre-contemplative, well, what can we really do about that? And I'll be going over harm reduction. I'll be going over other interventions we have, when they are kind of pre-contemplative. And then when they're contemplative, well, how do we move them from just thinking about something to actually taking action and doing it? In terms of and obviously MI would be the biggest one, but there may be some other options there. And so that's kind of what that will be. How, once they're in the maintenance phase, how do we prevent relapse? Because people will feel like that, okay, so once I get sober, everything's going to work out. Everything's going to be perfect. My life will be together. And they're very disappointed when they've been sober 3 months and their life is actually pretty hard. So how do you deal with that?
Okay, excellent. And that brings us to 129. So thank you so much for this was extremely enlightening, as someone mentioned, and also I'm excited about part two. And a reminder, who someone has their hand up. If you want to put your question in the Q&A, I can get it out. As I'm waiting to see if that comes through, we have another thank you so much for this informative presentation. I appreciate your time and knowledge. Looking forward to PowerPoints on part two from Tracy Brown. Let's see. I'm gonna go through all the thank yous. All right. I'm not seeing any further reminder. Watch your emails for the CEU and PowerPoint invite. Thanks again, Dr. Ghafoor. All right. Take care, all. Thanks for joining us. Bye.